Hi, today's blip is on brown Sequard syndrome and rapid pain. To understand this better, all these two concepts which are applied to the previous two videos, dorsal columns and pain pathway. Now we'll start with the brown Sequard syndrome. You can see here, because this is involved in one side of the spinal cord, that is hemisection of the spinal cord. So how these ascending and descending pathways are affected, how the physiological outcome will be, we'll see. So we'll start with the brown Sequard syndrome footnote. Then dorsal columns, here it is DC, you can see. These fibers are climbing on the same side of the spinal cord. This is the spinal cord and this is the midline of the spinal cord, you can see. Whereas the pain and temperature which was represented here, an orange arrow or a line, you can see all these fibers are synapsing in the spinal cord and crossing to the opposite side and they are ascending upward. And pain from the opposite side of the body, and they are represented in green color. Second order neurons are crossing immediately and ascending on this side. Okay, now we'll imagine that this part of the spinal cord is injured, damaged, maybe due to bullet injury or other possibilities. This is what is known as hemisection of the spinal cord, resulting in brown Sequard syndrome. Now we'll see the clinical picture. As the dorsal columns, which are ascending on the same side of the lesion, ipsilateral side, and the fibers are disrupted, so that the sensory pathways, sensory modalities carried by dorsal columns are completely lost. For example, what are the sensory modalities? Fine touch, tactile discrimination, tactile localization, vibration sense, proprioception, and so on. All these carried by DCML are disrupted on the same side of the lesion. Whereas pain and temperature, you can observe carefully, this orange mark is crossing to the opposite side and ascending upward to the brainstem and brain, so that it is not affected. That means on the side of the lesion, below the level of the lesion, only the sensations carried by the dorsal column are affected and lost, whereas the pain and temperature on the same side are preserved. They are uninterrupted and going on the opposite side, so they will go to the brain, and the sensation of pain and temperature are perceived because of the anterolateral columns or spinothalamic tract, which is crossing at the spinal cord level. Whereas if you see the perspective of the opposite side of the body, the pain, we'll start with the pain, green arrow line up here. This path is crossing from the opposite side to the side of injury and ascending upward, where it is disrupted by the injury, so that the pain and temperature on the opposite side are lost, and DCML sensations on the opposite side below the level of lesion are not lost, and dorsal column lesions, if you come back, are lost on the same side, but pain and temperature on the same side are preserved because they are crossing to the opposite side. Whereas these black arrow marks downward indicate the motor pathways. So motor pathway on the other side is not disrupted, so that the motor function is preserved. On the side of the lesion, you can see the motor fibers are disrupted, so that the motor function is lost below the level of the lesion. This is a simple flowchart to understand and present in the exam for brown Sequard syndrome. Next, we'll move to the referred pain. First, we'll start with the definition, what it means. The person feels pain in a body part which is considerably remote from the tissue that is causing pain. Now we'll see the frequent possibility. The pain is initiated usually from the visceral organ, that is the tissue which is causing the pain or which is damaged is visceral organ, and it is referred to the area on the body surface. Okay, now we'll see the different theories in referred pain. There are three different theories: dermatomal theory or dermatomal rule, then convergence theory, then third one is facilitation theory. Most explained and most reasonably believed that this is by the same second order neuron which is conveying these both the sensations because of the convergence of these first order fibers, and brain is perceiving that as the pain originated from skin surface. To explain this, we will take a flow chart. It is the easiest flow chart with which you can explain referred pain. Now you can see this is the visceral organ which is initiating pain fiber and initiating the damage. Then the pain is carried, and the blue line you can see on the screen. This is from the pain fiber from the visceral organ, whereas on the orange color is the pain fiber from the skin. Both are terminating on the same second order neuron, which is represented in bold arrow. When this second order neuron is climbing upward to the brainstem, It is same common pathway. Because of the convergence of these two different fibers on the same secondary neuron, the brain will perceive that this sensation is originated from the skin and resulting in a concept known as referred pain. Referred means the visceral sensation, that especially the pain sensation, is referred to the skin surface or the superficial part of the body. That is what is referred pain. We'll see now examples so that with that we can conclude. You can see most common is cardiac pain, which is due to myocardial ischemia or MI, heart attack, is felt in the part of the left arm and left shoulder. This is the best example we can quote from physiology and clinical practice. Then other examples you can see, pain in a ovary is referred to umbilicus, pain from the testis is referred to abdomen, lower abdomen, pain from the diaphragm is referred to right shoulder, renal pain, pain from the kidney is referred to loin, pain from the gallbladder is referred to epigastric region. So these two are simple concepts which can be asked frequently in the theory paper or in the viva, can be answered well if you can understand these basic principles on these two physiological phenomena. Okay.